Team, happy Thursday. Thank you all for hopping on. Today, you're going to see somebody who's slightly shivering in San Francisco, putting my socks on frantically. And you're going to notice a little bit of diaphoresis on Glenn's forehead. Why am I putting Glenn in the spotlight? Is because I finally get to discuss with him. Glenn has been part of the team for several months now, and the story of his involvement with the team really warms my heart. Our beloved and one and only Mark Heslin was doing an away rotation in Glenn's native Botswana, and long story short, Glenn has family now. I've been part of CP Solvers doing incredible work, and as you all know by now, the way we celebrate that is by making him sweat a little bit. So Glenn, I'll hand the mic to you to maybe introduce yourself to the audience, tell us how you're feeling, and then we'll welcome everybody else who's part of the case today.
Good morning, everyone. Just like Ravi said, I'm Glenn. I'm a medical student in Busan. I'm about to start my final year, and I've been part of this CPS community for like I think 4 or 5 months now. I've presented I think 3 cases now, and this will be my first time co-discussing with Ravi. And I think I'm ready. I've seen how it's done, and I think I can um try to give my best for today's case.
Yeah, we have no doubt about that, my friend. We have no doubt about that. You'll definitely give it your best, and we'll have a very good time. Before we reveal the identity of our beloved case presenter, I'd love to thank the people who are making it happen. And in the scribing role, we have Simi and Hans. So, Simi, maybe I can hand the mic to you to say hello, and then hand the mic over to Hans as well.
Hello, everyone. Excited for the session and excited for scribing and also for Glenn's first discussion. So, rooting for him and looking forward to the session.
Thank you, Simi. Hans?
Hello. Simi's doing the scribing today, so I focus on your discussions, but I'll scribe next time.
All righty, that sounds fantastic. And it is the dynamic duo that you're all familiar with because Lyra is doing teaching points today. I hand the mic to you, Lyra, to say hello.
Hi everyone. Yeah, doing teaching points today, gonna be capturing all the wisdom that you and Glenn gonna share. I'm very excited for your discussion, Glenn.
Yeah, I think today will be a three-part effort because our beloved Austin is presenting a case. And whenever Austin presents a case, I encourage you to listen very carefully to how he can construct a story, which we actually were talking about behind the scenes, but there's going to be some Austin pearls at the end, which is my favorite. I know that's his pattern because we're so lucky that Austin actually presents cases regularly behind the scenes to his twin brother, Alec, on our academy sessions. And every single time there's a trap that I fall into or a gem that I miss, and then Austin summarizes it at the end. So Austin, thank you so much for hopping on and presenting today. Full hour format. I'll hand the mic to you to say hello, maybe catch people up on what you're up to, and then we can jump in.
Yeah, no, thanks so much. Excited and honored to present. It's been a while, and I always reflect back at I think I presented case like 3 or number 5 in VMR history, and here we are into the 1,000, and I wouldn't have it any other way. I mean, such an amazing place to be, and still learning every single day from everyone in the community, and so if you're not joining, you're missing out, and FOMO is real. But we'll love you nonetheless, because that's the type of community that we are. But yeah, nothing too new in my life. Just started my new job. Tomorrow, I actually start on the wards in the hospital, so that will be a journey since I haven't done that in a while, but definitely excited to kind of get into that space again. And but I had this morning to be able to present, and so excited to do that as well.
Amazing. I see we have a furry friend visiting us, huh?
Yes, he was like yelling at some part of the house, so I think it was stuck somewhere, but he has
Oh
since been
no.
released,
Look
and
at
here he
that.
is on my lap.
Hey, you know what? No better place to hang out than VMR. Let's do this.
That's right. Yeah, so whenever we're ready, we can get started. Alrighty. So for the first aliquot here, this is a 25-year-old man, and he's coming in with acute onset abdominal pain. So just to give you a very small amount of information, he basically woke up from sleep with this abdominal pain. There's no vomiting or diarrhea. He tried to kind of tough it out to the morning because he thought it would go away, but it persisted. So he went to the emergency room, and I'll stop there.
Awesome. Yeah, Glenn, I think there's a lot to discuss here. I'm curious, when you hear the words acute onset abdominal pain, what are the life-threatening causes that cross your mind?
Okay. So for abdominal pain, usually I like to think of it um um just dividing it by the anatomical causes. So thinking of the abdomen, just dividing it into 9 quadrants. So um I'll be interested in knowing where the pain is exactly in the abdomen.
Mhm.
So if maybe it's in the right lower quadrant, I'll be thinking things like appendicitis. So basically, just in every quadrant, then thinking of the anatomy and which organs are there. In the right upper quadrant, I'll be thinking about those gallstones and things like that. Yeah. So for
Yes.
abdominal pain, I just like to think of think of it using the anatomy and for
I think you can
everyone.
definitely use anatomy to guide you. I'm curious, in general, whenever you're thinking about something, when you don't know the anatomy yet, sometimes what you can do is to think of the very life-threatening causes. So appendicitis is definitely a consideration, but I think that it might not be considered acutely life-threatening. So the reason I'm asking you this, Glenn, is sometimes when you don't know much information, the only thing that you can do is to say what can really harm the patient in the next few hours. So if you apply that filter until we know where the pain is and know more details, that's probably the only realistic filter you can apply right now. So what crosses your mind when you think of the most deadly causes of abdominal pain?
Um, so I can think of maybe ischemia to the small
Excellent.
bowel,
Excellent.
um, maybe peritonitis as well.
Absolutely superb. Those are the two most life-threatening causes, Glenn. So anytime somebody has acute onset abdominal pain, your mind is going to be fixated on those two things, especially if you get clues to suggest that. And we're rarely going to move beyond ischemia and perforation causing peritonitis. If there's anything at all in the history that is compatible with those two life-threatening possibilities. So if you hold those in your mind and say, is there anything here that makes you worried about those two entities? Are there features that you've heard of so far that are compatible with these two diagnoses? What do you think?
I think so far we haven't got much information to know more. So for peritonitis, I know we can get to know more in the exam, get to know rebound tenderness and things like that. For ischemia of the bowel, small bowels, still still can't rule it, out based on the information that we got.
Yeah, I agree with you. I think Glenn, it's so important that um, that the small details of the HPI come to life. So I want you to imagine this, Glenn. This patient told you, I went to bed and I fell asleep, no problem. I was comfortable enough to fall asleep. Then I was awoken by severe pain and I couldn't even make it through the day to get there. And I think that acuity, Glenn, is so captivating. Because if you imagine a patient with appendicitis, what's your guess about how long a patient with appendicitis will take before they come and ask you for help? How many hours or days? What do you think?
Peritonitis, I know they usually take some hours to up to a day.
Yeah.
So it's maybe like 6 hours or something.
Yeah.
And I know the pain would start central and then move towards the
Exactly.
anatomical area.
Yeah, most of the things that we think of in abdominal pain usually are at least a day, if not a couple of days old. So the classic patient with appendicitis or diverticulitis or cholecystitis has a lingering pain that begins not abruptly, doesn't wake them up from sleep, and usually builds up over a day or two, leaving the patient only convinced that they need help after a day or two. And so here, Glenn, honestly, my mind is not able to skip over the life-threatening causes of abdominal pain because this patient is behaving so differently than almost every other patient I've had with abdominal pain because of how ferocious and aggressive and fast this process is, to the point where he seems to be in the emergency room hours after this developed. So this to me is not a walk or a run or a bicycle or a car or even a plane. This is a rocket ship going straight into space. And that doesn't necessarily mean that the patient has a problem that's a rocket ship. Sometimes the patient's reaction to a problem may be disproportional to the problem itself. But so far, with this information, if we don't do anything about how quickly this is progressing, our patient's heading in a direction we don't want them to head. So for me, I'm very perked up, eyes wide open, pupils dilated, and I'm really curious to see where this case goes. Right back to you.
All right, yeah, superb discussion. And so, he makes it to the emergency room. The vitals are totally normal. He gets some routine lab and urine tests done. All of them were normal. They did kind of multiple modalities of imaging. So they did an abdominal ultrasound, a testicular ultrasound, as well as a CT, abdomen and pelvis with contrast. And it was notable for a spleen of 14 centimeters and some bilateral epididymal cysts. Otherwise, there was no other abnormal findings. And so he was given just basically some supportive care and then discharged to the care of a GI doctor in outpatient setting. And so 2 months later, the patient comes to see you. Okay. And since that time, the pain has not resolved since it began, but it kind of waxes and wanes in intensity. It's primarily in the right upper quadrant with some radiation to the epigastrum, the chest, and the groin area. When it's more mild, he describes it as bloating, but when it's really intense, it feels like a stabbing pain, mainly in the right upper quadrant, and it lasts for hours at a time. There isn't any associated exacerbating or alleviating factors that he's appreciated so far. And then he was using some over-the-counter analgesics like Tylenol, ibuprofen, which were initially helpful, but since over the last 2 months, they've just become ineffective, so he's not using them anymore. A new thing that's happened is that he's now experiencing episodes of vomiting. They occur once like every few days. They're bilious in appearance, but there's no blood. And he's also been having some kind of worsening heartburn or reflux during this time. For his review systems, he's lost about 15 pounds over the last month, and he's feeling very fatigued, just generally very fatigued. Otherwise, when he gets these more severe episodes of pain, he feels like he has chills but no fever, and he's tried to measure his temperature and it's been normal. And then the only other thing he's noticed that sometimes the skin in the area that hurts, so in the right upper quadrant area, can sort of look a little bit different in color, but he's never seen a rash or anything pop up. So a lot of information. I'll stop there for you guys to reflect on that.
Wow, what an intriguing twist. So, Glenn, I know there's a lot of information here. I'm just curious where your mind is flowing to spontaneously. Why don't you tell us what you're thinking?
Okay. So firstly, I was thinking that where the pain could have been coming from initially before the second complaint. So the patient had epididymal cyst and I think splenomegaly, if I'm not mistaken. So from those two, I'm thinking what could have caused the pain from there. But then as the history of presenting complaint continues, he the patient has some red flags like weight loss, which and fatigue. There's no fever, so I would maybe think of any malignancy. Thinking of the splenomegaly and the weight loss, but then the patient's age is not um it's not the age range for malignancy. And also there are some vomiting that was noted, bilious vomiting. So that would mean, especially with the right upper quadrant pain, there could be some bile duct abnormalities there. Not too sure what exactly. Yeah.
Glenn, are you having a lot of difficulty putting this case together?
Yes, I feel like there are a lot of individual things to talk about, but yeah, I'm having trouble like putting them together.
It's very hard. I'll tell you, this case is very, very difficult to put together because I think, well, maybe I can ask you one more question before I try to explain why this case is very hard, actually. So, how would you rate your confidence, maybe with the options of mild, medium, or high, that the things you found on the CT scan, splenomegaly and epididymal cysts, explain the patient's pain? Are you confident that that's the case? Maybe or not sure. What do you think?
I'd I'd go for maybe, but I'm not confident that splenomegaly and cyst can cause that much pain.
Perfect. Perfect. And then maybe let's zoom in on that. Which would you think is more characteristic? Are you using the epididymal cysts more or the splenomegaly more? Which do you find more valuable to your case?
Um, I know most of the patients I've seen with splenomegaly don't complain of pain. They don't complain of pain much, but then the pain here is mostly in the right upper quadrant, so
Yeah.
which near the anatomical location of the spleen as compared to the
Yeah.
epididymal cyst. So I will lean more to splenomegaly.
Excellent. Superb. I'm right there with you. And I'm here to show you that the difficulty you're having is actually not because of any deficiencies in your own knowledge. It's actually that the fact that the patient is telling you they hurt in the right upper quadrant, and the radiologist is telling you there's something wrong in the left upper quadrant and something wrong in the testicles. So how you put those two together is actually a question of trust. Who do you trust? Do you trust the radiologist is telling you that that they are picking up the right abnormalities, or are you trusting the patient's nervous system to tell you where the disease is? Because the nervous system is saying, hey, the nerves in the right upper quadrant are fine. And so I think it's a matter of trust, and it becomes very, very hard to make progress because what you're going to try to do next is to say, okay, well, how can I line things up? Because it becomes very easy to know what to trust if there are a series of abnormalities that actually line up together. So if Glenn, we later learn that the patient has marked pyuria and severe epididymal tenderness to palpation, then our trust issues become less ominous and we start to line up on the epididymal cyst. If we later learn that the patient has pancytopenia and has an abnormal peripheral blood smear, then it becomes easy to focus on the splenomegaly. And I think my trust issues in the radiographic fingerprint of this disease are reduced by the fact that there is no correlate whatsoever to those two radiographic findings. There is no CBC abnormalities associated with the spleen. And as I've shared with you all privately in the academy, the answer to splenomegaly is by analyzing the CBC. And if you don't trust me on that, just go back to Wednesday's case, review the whiteboard, watch the YouTube, and look at the splenomegaly and the CBC, and that will tell you the answer. That's all you need. So here, with no CBC abnormalities, we should repeat it. I would say that I think the splenomegaly may be noise. And depending on how you measure the spleen, you may come up with numbers that are really essentially borderline. And the fact that the spleen wasn't noted on the ultrasound is another interesting element of the trust gap we have here. So to be honest with you, Glenn, where I'm at is I'm calling the radiologist and thanking them for noticing these abnormalities, but I'm not using them because I have most trust in the patient. Because the patient is almost always, unless they have a neuropsychiatric condition or a substance on board, they're always right. So let's talk about the right upper quadrant pain here, acknowledging that the other things may come and take more space. So if you focus your thinking on the right upper quadrant pain, where does that take you?
So right upper quadrant pain together with the bilious vomiting. So my differentials will be centered around the biliary tree. So so things like stones, but I know this presentation is not a typical presentation of stones in the biliary tree. Also, there's a range of them. There's biliary colic, cholecystitis. So yeah, I'm thinking around those causes for now.
Very good. A very simple formulation of his right upper quadrant pain is that the pain is the nerve being irritated. And you, Glenn, are appropriately asking why. And I think we should be worried about what the cause is because the patient has had lost weight, has fatigue, and has chills. And that is suggesting that there is a consumptive process causing the pain. And the consumptive process is likely in the area of the pain. The problem is that we have yet to find any clues of that consumption on labs or imaging. And so the first step is to reassess, since now it's been 2 months, whether we can now see the clues of that consumption from labs or imaging. If we cannot, we'll have to reassess whether pain is a response to a consumptive process or whether pain itself from a primary nerve issue is driving the consumptive process. So hold in your mind a very simple equation: pain and all these other symptoms, weight loss, fatigue, consumption. The operating hypothesis has to be that consumption is causing pain. The good news is consumption will someday, maybe in a delayed way, 2 months later, be detected with the labs and the imaging. If after reassessment, there is no laboratory or radiographic fingerprint of consumption, we have to question which way the arrow goes and start to wonder, is there a primary nerve problem that's causing the consumption? So right now, I'm right there with you. Just because he was assessed once with the same test doesn't mean that they're perfect. All these tests are flawed. So I would probably proceed with a reassessment and see where that takes us. All righty. Where are we going next? Oh, Glenn, we're in for a ride today, I can tell.
Yes, no, that was incredible. And to make things more complicated, here is his kind of rich background. So basically, he has a medical history of depression. He sees a psychiatrist. Generally had been well controlled, but with the degree of symptoms he's been having, he's been it's become really socially isolated, has not been able to go to work. And so understandably, his mood, has really worsened during this time. He has, as a child, he had Henoch-Schönlein purpura, but as far as any like kidney disease or sequela from that, there's nothing that's known. It just resolved on its own. And then from a GI standpoint, I started asking him, is there anything that you've experienced in your life that is, similar to this or related? And so he says that for pretty much all his life, he had like a weak stomach, so to speak, where he had for years kind of like intermittent episodes of nausea and vomiting. But in the last year, they had become a little bit more frequent, like happening every few months. There was no significant pain during those times, but he just like constant vomiting, regardless of like what he was eating or what was in his stomach. But they would always self-resolve. He never had to go to the emergency room or anything like that. And the only thing that he had similar pain-wise was about a year ago. He had an episode of abdominal pain due to like stressors at work. It was similar in character, but not nearly as intense. But after he quit his job and was able to find a different employment, things really improved. And up until his symptoms began, most recently, about 2 months ago, he was doing really well. His mood was in a good place. His job was in a great place. His social life was in a great place. But everything that's been going on has been really affecting him. So from a family history, he has multiple first and second degree relatives with hereditary spherocytosis. And he also, and his dad had his dad had an early MI as well as a carotid dissection that was spontaneous, but there was no sort of autoimmune disease history in his family. And then socially, I sort of gave you some background. He worked in an office job. And from a health-related behavior standpoint, he uses marijuana daily, which he smokes and has been doing that for some time. And he also has vapes. There's not been any change in like where he's getting the marijuana from or the amount that he's using. Because of his symptoms, he stopped using marijuana for a couple of weeks, but he didn't notice any significant difference in his symptoms at all. And he doesn't drink any alcohol, doesn't use any other substances. He's not currently sexually active. And then he takes a few medications, but nothing that's particularly relevant. And so I'll stop there for now. And I might need to add some, combine some aliquots here and there or just information, that's fine. But I'm trying to take you to where I was when I was taking care of this patient. And so I'd love to hear your reflections on the background.
Yeah, for sure. Yeah, Glenn, what does this do for you?
So yeah, there's been a lot to digest from.
For sure.
So I'm thinking about the intermittent episodes of nausea and vomiting. I'm thinking if they could be related to depression. I know sometimes patients with depression can have this medically unexplained symptoms. Also looking over the past medical history, the handling the purpura, the IgA nephropathy. I'm not sure about the complications of it. I know it causes kidney abnormalities, can cause
Good.
blood in the urine and all that, which is not relating to this case. Also, history of carotid dissection. I don't know if it's really will help us in this case, and the history of early myocardial infarction. I don't know if it means there's a family history of maybe a hypercoagulable state, maybe like a factor 5 Leiden mutation that runs in the family and can predispose to early MIs. And also they mentioned family history of hereditary spherocytosis. I think in this case, we can entertain it based on the splenomegaly. But then we'll have to find out if there are any signs of hemolysis to suggest if maybe he could be having the hereditary spherocytosis. But then again, are we struggling to put everything together into one?
Yeah. Yeah, I'm right there. I'm struggling with you too. I think ultimately, when you're visiting with a patient, you have to know that there's two people in the room, not one. And I'm not referring to their family members. And the two people in the room are the patient, of course, but also there's this entity that nobody wants to be there that is there. And the thing that you're trying to rid the room of, and that's the disease they have. And acknowledging that third person in the room is very important. And studying the relationship that the patient has with their disease process is very key. In fact, we rely so heavily on how the patient describes their relationship with their disease for us to try to figure out what it is. You have no hope of trying to diagnose a disease in a patient who's obtunded without any information from family or family members because you don't have access to how their patient is interacting with their disease in a reliable manner. And I think the reason I'm bringing this up is because the patient's relationship with his disease is undoubtedly complicated by his own psychiatric history, his substance use, but also the very rich family history of illness. And I think that when you're 25 and you've been in an environment like this, it definitely impacts you in some way, shape, or form. And I think acknowledging that impact is going to be very, very key. And so as you hold and try to understand understand how the patient's pre-existing psychosocial circumstances influence how they talk with their illness. At the same time, here, I think the fact that there was a hereditary familial condition that affects the spleen no longer keeps the spleen as an isolated radiographic finding. There's now another correlate with it. And so we must wonder, does this patient also have hereditary spherocytosis? And the problem with hereditary spherocytosis is the degree of hemolysis can be so mild that a patient may have a completely normal hemoglobin, as we heard. So I think the line of querying now has to include whether a patient has this condition and whether he is vulnerable to the consequences of this condition. And so for the sake of time, we can save that conversation for the next aliquot, but I think the family history here is certainly interesting, especially since the patient seems to have the splenomegaly. All right, Austin, what do you have next?
Yeah, no, beautiful distillation. And you really touched on all the points I was hoping you guys would touch on. So for the exam, vitally, he's afebrile, blood pressure is 129/76, heart rate of 100, breathing 20 times a minute, satting 99% on room air. And he's a tall and thin guy, so BMI of 21, and he's about 6'4" and 175 pounds. Generally speaking, he's non-toxic appearing, but he's like very uncomfortable due to pain during the visit. There's no jaundice, and there's no like abnormal facial features or anything that I could appreciate. Heart was regular and tachycardic, but no murmurs. Lungs were clear. Abdominal exam, he was soft, non-distended. There was no rebound or guarding. He was diffusely tender, but more so in the right upper quadrant. There was no rashes on the abdomen. For his genitourinary exam, he had very good femoral pulses. There was no obvious hernias, normal genitalia. The testicles were not tender, and there was no inguinal lymphadenopathy that I appreciated. And then extremities, no edema. His nails appealed normal. There was no petechiae, there was no hypermobility. So that's the exam. And I'll just say, like, towards the end of the visit, it turned out that the patient had seen a GI doctor the prior month and had a few tests done, but didn't know exactly what tests were done, but wasn't told that anything was abnormal. So we sent to get the records of that. But based off the exam and everything you've heard so far, I'd love to just hear about how would you proceed next? Like, what tests would you order and how would you move forward to try to help the patient?
These are fantastic questions. I think this is such a rich case that maybe we should, Glenn, have you mix your thoughts in with your CPS colleagues. So let's just do a 3 to 4 minute breakout room. I think Austin's question is a fantastic one. So this patient's right in front of you. What would you do next? We'll just do a 3 to 4 minute breakout room and reconvene. And I see you got to hang out with some of our VMR guests and of course Parisa. What were your thoughts after that conversation?
Yeah, I got to learn it. I think too from them. So entertaining possibility of a late presentation of hereditary spherocytosis. So we're thinking of doing this smear, and also doing repeat of the CT abdomen and pelvis with contrast. Yeah, and then for my earlier, before we thought of that, I was just thinking of just right upper quadrant ultrasound because of the pain that he had in the right upper quadrant, just to visualize the biliary tree.
Absolutely superb. Yeah, I'm right there with you. I think if I were to arm you with how right upper quadrant pain can evade radiographic detection, I think the most important diagnosis to entertain is celiac artery ischemia. And so what can happen is the celiac artery can be occluded, often from the diaphragm, in a condition called median arcuate ligament syndrome. And patients can get recurrent episodes of subradiological pain, mostly in the right upper quadrant, because that's what the organs that the celiac artery perfuses. So that is on my mind. And that will be important to tell the radiologist it's on your mind so they can look at the CT scan with contrast that you ordered very well. The other possibility is that it's a disease of the liver capsule, another subradiological structure in the form of Fitzhugh-Curtis syndrome, which often represents a consequence of gonorrhea or chlamydia. And so you might think of that entity specifically. Gallbladder stones and biliary disease often has some radiographic clue, but the presence of biliary sludge can be easily missed. And biliary sludge is an important consideration in a patient who has possible hemolytic disease. And so I think that ultimately one question to ask is, should we get a HIDA scan? A HIDA scan is a radio labeled scan that allows you to figure out how bile is moving through the biliary system. And I think that is on the books for the patient, though it's probably too soon for that. And then finally, if I'm re-emphasizing the list, and to answer David's question, yes, it does. It's a really cool disease entity. Celiac artery, liver capsule, sludge, and then finally the nerve. And the nerve is really important here. And I'm saying this not because I would have thought of it in real time, but I think if you just apply the filter of the most common causes of what this is now, this is chronic abdominal pain. One of the most common causes of abdominal pain is nerve entrapment in the skin, and an entity called ACNES, anterior cutaneous nerve entrapment syndrome, commonly affects people and commonly actually presents in the right upper quadrant. So one thing that I might do in this patient is to pay very close attention to their abdominal exam and see if they have hypo or hyperesthesia in a very specific spot in their belly that I can point to with a finger. And I might even empirically just do a subcutaneous lidocaine injection, ultrasound driven, if I had the expertise that Austin does, to try to see if I can relieve the pain for this patient. Those would be my prioritized tests, but in reality, Glenn, like you, I would probably reassess the whole lab, get basic labs again, get a peripheral smear, get a reticulocyte count, get a CT abdomen pelvis with vascular protocol. And then I would wonder, hey, do I need to get gonorrhea, chlamydia? Do I need to get a HIDA scan? But a very simple bedside thing I could do right now is to do some subcutaneous lidocaine in the distribution of the anterior cutaneous nerve. But we've talked so much, I didn't realize that we're almost there. So let me hand the mic to you, Austin, to guide us next.
Yeah, beautiful. I'll combine a few things. And yeah, I can't stress enough how often the nerve entrapment the diagnosis is missed. And so it's really, really good to think about that. And I haven't done the injection, so they are quite simplistic when you YouTube about how to do it. And as Noah mentioned, it's therapeutic and diagnostic. So to answer some of your questions, yes. So what I did was I ordered another CT scan. This time I ordered it as a CTA, and there was patent vasculature. There was nothing that looked of concern with the sort of celiac or the mesenteric vessels. And it did note the mild splenomegaly at 14 centimeters again, as well as some stool burden. But otherwise, there was no abnormalities in the gallbladder. I also did a duplex of the mesenteric vessels, and everything was patent with, though there was like some non-specific elevated flow velocity in the SMA. But they, unfortunately, when I talked to the radiologist, they didn't have any comment or couldn't comment on the respiratory cycle and how things changed with the respiratory cycle. As far as the labs that I repeated, so just as you guys said, I checked another CBC, totally normal, hemoglobin 14.4. He actually saw a hematologist during this time, did a hemolysis evaluation. That was all negative. And then they did check a smear, and it did show a few spherocytes. So they diagnosed the patient with hereditary spherocytosis. The chemistries, all normal. So liver enzymes, AST was 14, ALT was 21, bilirubin was 1, totally normal. He had a lipase that was normal, urinalysis that was normal. And then other sort of testing that I did, so HIV was negative. I did some serum or image negative abdominal pain relevant testing like lead, and even got the urine porphyrins, and then also cortisol testing, and all of those came back normal. And then you get a I also did some sort of like symptomatic management, like gave a PPI, some other medications. Like, unfortunately, the patient didn't have really any improvement in their symptoms, and then actually had sort of like progressive worsening of their pain as well as the GI aspect. It really noticing a lot more of postprandial disease now. So 10 or 15 minutes after eating anything, the patient's symptoms would really flare. But you eventually get the records from the GI doctors, and the patient had an EGD with some random biopsies. Everything was negative, and the appearance endoscopically was normal. And then he did actually get a HIDA scan with CCK administration, and it didn't show any evidence of a blockage or cholecystitis, but it commented that the gallbladder ejection fraction was 82%, with the normal being 40 to 60%. So love your reflections from here. And I think I can just reveal the final diagnosis after this aliquot.
Fascinating. All right, Glenn, what are you thinking?
So my reflex thoughts for now is that the spherocytes in the smear. So I'm thinking if that's probably the cause of the splenomegaly in the first place. But then if it's been going on, that means the patient has been compensating well. I mean, there's no signs of there's no signs of hemolysis of no no jaundice and all that. But then I'm thinking, how can spherocytosis then cause the abdominal pain, especially on the right upper quadrant? So maybe patient is having the hereditary spherocytosis with some other thing going on at the same time. So that's what I'm thinking it. And also the differentials that we mentioned and are now ruled out. I mean, occlusion of the celiac artery, like we mentioned, is now ruled out and all that. So I'm thinking there could be something that's going on together with the hereditary spherocytosis.
Yeah, I think your if you watch this again, Glenn, when you're an attending, I think you'll be very proud. I say that because you are trying to force an answer, and yet it's hard. You're acknowledging that when patients have a relatively unusual condition, hereditary spherocytosis, that it's tempting to try to merge them together, but you haven't found anything to merge it with. And so you're open to the possibility that it could be something else, but at the end of the day, trying to link things together. And Glenn, it's such an interesting thing to ask yourself. How could somebody be suffering so much, losing this much weight, and yet have such underwhelming results? You know, how could you see this person suffering miserably, potentially from childhood, to you not being able to see the problem? And I think there's really one of two possibilities from that very simplistic frame. Either you'll never be able to see the problem because it is microscopic and small, or you're not looking right. And you need to look differently and find another way to look. And I think that's what's creative about the HIDA scan, is it's a creative way to look at the gallbladder. I have no idea what a hyper ejection fraction gallbladder is. And to stay authentic to the exercise, I would probably ignore it until I learn more. But I do know, Glenn, that that dynamic ischemia is a real issue. And so if we go back to all our hypotheses, the celiac artery compression hypothesis, unfortunately, has not yet been fully exonerated. And the reason for that, Glenn, is that most of the time, the patients do have evidence of consequences of compression of the celiac artery by the ligament of the diaphragm, causing aneurysmal dilation of the celiac or some stenosis of the celiac artery. But in some patients, you will only be able to see the compression in very specific protocol CT scans when the patient is having inspiratory and expiratory phases of the scan. And so this dynamic compression disease is very difficult to diagnose and can be diagnosed through multiple different ways. You can actually do an endoscopy and measure perfusion into the stomach as the patient breathes in and out. And they use carbon dioxide as a correlate for how much blood the stomach is getting. You can also do a celiac plexus block and watch hopefully for the patient, the pain go away with a denervation of that area. And then, of course, you can do dynamic imaging. So not just a static CTA, but a dynamic CTA with inspiratory and expiratory views to see that. And the reason I'm more worried about it is he is the perfect patient to get it because he has a low BMI, and the loss of the protective fat pad in the belly predisposes patients to get this condition. And now his pain is more postprandial, implying that with normal gallbladder function, normal LFTs, no gastric ulcer, no pancreatitis, that perfusion may be a problem. So I don't know this to be the case in this patient, but I think it's important for all of us to remember that long-standing episodic focal image negative right upper quadrant pain still has one pretty serious diagnosis underneath it. And that's a dynamic compression of the celiac artery or median arcuate ligament syndrome. Gosh, I can't say it. So, Glenn, either from my abilities, will never really know confidently what the patient has, or he has a classic presentation of celiac artery compression, which is so hard to diagnose, takes a lot of convincing of vascular surgeons and experts to do the testing. So that's what I would propose for us to do next. And before we hand the mic to Austin, I'm curious if you have any clarifying questions about that or anything that I didn't explain well.
I have, for me, I'm not too familiar with the test for compression of the celiac artery. But you explained it well, why we are doing it, and I'll have to review more on it.
Yeah, wonderful. All righty, Austin. Really, really curious how this panned out. Teach us, please.
Yeah, so definitely felt the same tensions that you did. And basically, going back, there was some constipation on the scan. So just made sure the patient was having bowel movements, made no difference. I called and talked to a psychiatrist to see, hey, we've sort of arrived at this endpoint where he's having these all symptoms. We've done all this evaluation. It's been negative. And even the patient himself was like, hey, everything's been negative. Is this just me? Is this happening to me in my mind? And going back at his history before when he had periods of depression, he'd never really manifested prominent somatic symptoms like that. And so, long story short, this patient was actually diagnosed with biliary dyskinesia. And so I wasn't authentic to how it happened, but basically I got the HIDA scan results like within a week of the first time I saw the patient. But I wasn't familiar with this entity, but after reading about it, I was like, maybe his symptom complex is consistent with that. But as you mentioned, it's so hard to diagnose definitively the vascular hypothesis. And so really was trying to pursue that as far as I could at the institution I had. It so happened that the surgeon that I referred him to, she had quite a bit of experience with this diagnosis, in particular, the hyperkinetic aspect of biliary dyskinesia, which is essentially falls on the same spectrum of a functional disorder of the gallbladder. So we sort of learn about the disorders of the gut-brain interaction. And so this falls in that spectrum. So the hypokinetic gallbladder is the most common manifestation, but hyperkinetic is well described. And there's a criteria for it. So there's the same Rome criteria, which he meets the criteria for. And then in her experience, there's no we don't understand the pathophysiology entirely, but her suspicion is that this is all sludge related. And even if it's subradiologic, probably there's some amount of inflammation or dysfunction that happens related to a reaction related to the sludge. And when you remove the gallbladder, this is why the cure rate is so high. So most patients will get cured from this condition when you remove the gallbladder. It's like more than 80% will be cured. So I was ordering I got the Doppler ultrasound the day before he went to the OR, and I really waited as long as I could to send him to the surgeon because I was just not really. It was really truly a diagnosis of exclusion, from my opinion. Like we need to entertain the vascular hypothesis as much as possible. I even talked with the surgeon that I guess sometimes during the procedure, if you could try to get a view of the mesenteric vasculature under the diaphragm to see like in the OR if there's signs like of compression. But her suspicion for that was low. And as you said, it's difficult to convince people to do that. But basically, he did tremendous. The gallbladder is out. His pain resolved. He gained all of his weight back. He was functional again. He got his entire life back. And this was one of the most challenging cases that I've ever tried to help a patient with. And I'd say the main reflection is that, when you can kind of walk, and you've talked about this before, but you can kind of walk closely beside discomfort when a patient has discomfort. Like you don't want to ignore it or sit down. You want to walk with them in it. When someone has dysfunction, you got to stand in front of the dysfunction and say, man, this is impacting his entire life. And that I have never not made progress with the patient to find a diagnosis if they're experiencing this level of dysfunction. Right? His whole life was destroyed in months related to this, and why he experienced symptoms in the way that he did, which what most of us would sort of consider a benign condition, all things considered, based off the other hypotheses that we were entertaining. Again, there's so much that goes into why people experience pain a certain way and how they manifest their symptoms in that way. But the dysfunction is always a clue to something being wrong and the problem that you need to solve. And so could he have vascular compression still? Yes, he could. And maybe months later he'll develop a recurrence or this will happen. It's possible, but the resolution of symptoms and everything was really, really telling and was incredibly rewarding to challenging, but really rewarding to go through this case. So yeah, you guys touched on everything that I wanted. I'm surprised that we didn't run further. You guys managed the time really, really well. So, thank you so much.
I knew we had a treat in store for us today. I've never heard of this entity before, and I'm really, really excited to reflect on it. But ultimately, for me, the biggest takeaway is just to see what peak primary care looks like. I think in at least in the United States, in an era where patients are increasingly disillusioned by us because of our understandable pushes towards having to spend more time away from the patient and more time documenting and doing other things. For you to just literally show us how you walk this patient all the way, literally without leaving their side until a final answer, and ultimately achieved what our job is to do, is to get relief for the patient. So it doesn't matter if he has compression, it would be asymptomatic at this point, right? And the fact that he's doing great is just so wonderful. I got to tell you, this is one of my favorite VMRs of all time, not just because it's a diagnosis I hadn't heard of, but I really, I think, symbolizes what I want to be for my patients. And I think to do that over months I get to do it over hours. To do it over months is a monumental feat. So massive kudos to you. And equally massive kudos to you, Glenn, for being open to, to this being. We don't know if this is related to hereditary spherocytosis or not. At least I don't. But I'm curious, what are your reflections on this diagnosis? How did it feel to discuss? I think Glenn is frozen. Oh no, what a time to freeze, huh? No. Or am I frozen? I can't tell. No, I'm not frozen. Okay, all right. Maybe we'll come back to Glenn in a moment when he's not stunned by the amazing diagnosis. Lyra, take it away, my friend.
Yeah, this was truly a session after which I feel frozen. And I'm really happy that it was recorded because we had on one of the Sunday VMRs a case of biliary dyskinesia. And yeah, it's really cool because I'm definitely going to rewatch this. And yeah, I just wanted to emphasize, because we're already in overtime, I just wanted to emphasize that we need to always take results with the imaging with a grain of salt and not attribute patient's symptoms automatically to what we find on the imaging, because it still could be noise, and we need to ask ourselves, can the findings on the imaging explain the presentation? And same, I believe, goes for labs. And if not, then we always need to ask a question who to trust, and the patients know its disease better. So we always need to trust the patient more than we trust the imaging. And when we really do all the workup and it still comes back negative, we are finding ourselves in a space of invisible yet severe disease. And to understand why can't we see this disease, we really need to take a step back and look at this and understand that it's either could be microscopic, so we just can't see it. Either we need to change the perspective, and we're not looking at this and not searching for it the right way. Like, for example, in cases of dynamic ischemia, we need to mimic the presentation of disease with imaging that we're gonna do. And when we exhausted these options, we can think of functional disorders like biliary dyskinesia, as it was in this case. Yeah, thanks everyone. This was a blast.
Absolutely incredible recap. That was so cool. The invisible disease made visible by Dr. Austin. That's so cool. Glenn, we were hoping for your reflections. How did it feel to discuss the case? What do you think of this diagnosis?
Yeah, again, thank you for the opportunity to share my thoughts with everyone. And it was a difficult case, and thanks to Austin for simplifying it in the end and explaining about the condition. I really enjoyed how we got to break it down until the end. And I'd say I would need to read more on biliary dyskinesia and also the tests that we can do to diagnose it. But I enjoyed the session today. Thank you very much.
I hope this is the first of many discussions, Glenn. You were so cool, calm, collected, simple, logical, clear. And I'm sorry I couldn't guide you to the ultimate destination because I have not been there myself, and I'm excited to read alongside you and learn alongside you. It was a real treat. All right, guys, thank you for an awesome hour, and hope to see you all later. Bye.